Thank you. So now we're going to move on to agenda items number 6, perhaps in collaboration with number 5, since they're both part of the Department of Health Services and Mental Health Services. So Dr. Belavich, thank you for responding to our request to share with us some information about mental health services, since we've had a number of concerns from a cross-section of inspections about the mental health needs that have presented concerns about the extent to which they're able to be efficiently and effectively attended to. Dr. Belavich?
Sure. Thanks for asking me, Dr. Grills. We had talked a couple of weeks ago about some of the concerns that I wanted to bring here. And, you know, the simplest way to explain it is that our mental health population has exploded in the last 5 years. In 2016, it was about 3,500. Today, we're at close to 6,900 in our mental health programs. That's close to half of the jail population. The jail population we've also seen getting more acutely ill. So we have a longer wait list for our inpatient beds. We have a much higher population of acutely mentally ill. 5 years ago, we used to have 400 or so in the acutely mentally ill population, maybe 500 when things were really bad. Today we have about 1,200 that fall into that category. So the acuity and the sheer number have made it such that it's impossible to provide adequate treatment in this facility or in the jail system. Nobody wants to receive health care or mental health care in the jail system. But unfortunately, for a lot of the people in this county, this is the place where they are getting any kind of care because they are ending up, you know, within our walls, unfortunately. We had hopes when COVID was going on and we went down to 12,000 individuals that we would maintain there. We have not. The overall population here at the jails about 14,600. So the problem we experience is, given the fact that we have over 6,500, close to 6,900 in mental health programs, we don't have appropriate beds for them. For example, we used to only house the mentally ill males here in Twin Towers. We've had to resort to housing them over in Men's Central Jail, which is something we don't want to do. It's a dangerous place. It's an old place. There's a much higher risk for people to harm themselves over there. But we in terms of healthcare, don't have a choice. The only other choice you have is what you've seen in the IRC, is where people sit for a long time waiting for a bed. We have had very limited success in getting beds for these individuals elsewhere. So the county, I know, works very hard on diversion, but it's not happening quick enough, and it's not happening to the degree that is having an impact here. You know, I know Commander Macias spoke about some plans and changes where we expanded at North Facility, where we have housed individuals up over at Men's Central Jail. Those are all things that were made. They were forced decisions that had to be made. They were not what we want to do in terms of housing the mentally ill. We continue to be under DOJ oversight for, obviously, our mental health program, and we will likely remain so for quite a while because it's impossible to provide this level of care of treatment to this number of individuals. There are just simply too many mentally ill individuals here in the jail.
Yeah, I'm curious.
Oh, you know, I'm sorry. One other thing. Before we hit questions, one other thing I'd like to say is part of the reason that we are in this predicament that we're in is we're the only place that cannot say no. The courts send people, and we have to take them. We try to send people to urgent cares on a 5150 upon release, and we're told they won't take them, or we're told they're at capacity, so they can't take them. So everyone else gets to be at capacity except the jail. CDCR gets to tell us they are not taking our people. The Department of State Hospitals gets to tell us they're not taking our people. We're the only place that doesn't get that option. We don't get to go on diversion. Sorry, I think, Mr. Sherman, you
Yeah.
were starting with a question. Sorry.
Yeah, thank you. I have a number of questions. I won't ask all of them, but out of deference to my colleagues. But you know, my understanding, as far as the only being the only facility that cannot say no, I mean, my understanding is that the sheriff has authority to say no to new admissions of people to the facility or to release people who may be incarcerated unnecessarily based on the Rand report. Um, so whether this facility can say no or not seems, I'm not quite sure that that is completely accurate. Is that your, I mean, are you familiar with what I'm speaking?
I am. I would defer to custody on their ability to release. That isn't my area of expertise, but I have to see everybody who's brought in and placed in front of us.
So,
From a healthcare perspective, I can't say no.
So I understand that what we are observing in well, almost every visit I go, uh, there is a complaint lodged with me by an inmate that they have not seen a doctor for months, 3, 4 months at least. On my a recent visit, I went with Joan Hubble. We encountered people who were complaining of just that, and I understand there is a need for more medical staff. A persistent need for more staff to handle the population's needs, but uh, what I'm not clear on is whether there is a system in place for triaging the needs of the lower acuity patients. I understand the court orders, the federal um, court orders relate mostly to the high acuity needs, but when it comes to people who may not have an emergency, what is the system for ensuring that people's needs are being met in a reasonable time frame? Whether those requests are not being neglected and leading to worse outcomes. I understand an emphasis on emergency care, but what I'm not seeing or I'm not understanding is how the chronic conditions, the chronic lower level conditions are being addressed as well.
Yeah. So, yeah, good question. Absolutely, staffing is a huge issue on both the medical and mental health side, and that would include nursing as well. Um, there's a health service request function where individuals can put in, it's a paper system where if you have a healthcare need, you can put in a request to be seen, and then those requests are triaged by a nurse, and it's given a level of acuity if it's an urgent request or a routine request. But I can tell you that system is very broken. It's a paper system. With a jail this large, we get over 10,000 per month of pieces of paper that have to be triaged and sorted. It's a very broken system. Other correctional systems have been able to obtain funding and invest in an electronic system, like an iPad system where individuals will put their request in to be seen, electronically, and it gets uploaded and triaged in a much more expedient way. We don't have that ability. We don't have that funding to do that. It's something that we've been seeking and are seeking. But you're absolutely right. Given the staff we have and the number of patients we have to focus on those who are the sickest. And so those with lower level needs do get overlooked.
So there's no system for, say, a request that's older than 2 months or 3 months, to receive a second look. Has this person, how is this person doing by a nurse? Does their is their request still live? Do they still have the need that they thought they had 3 months ago? There's nothing there like to reach those people.
So actually, when the requests get triaged, they do get scheduled, and they don't get scheduled 2 and 3 months out. So if the individual, for example, he might get an appointment in 3 or 4 weeks. The problem comes when on that day in 3 or 4 weeks he's out to court. Then he has to get rescheduled again, or they don't put him at the end of the line. They try to reschedule him, sooner, but it could get kicked down the road. And there's also a lot of waste. We schedule people off of these papers that they may be released, and we aren't fully aware that they're released. And so we've held a spot for them this day that, they're not going to take. So we can slide someone else in who, who has an emergent more emergent need or something like that. It's a very imperfect system, and there are people who do fall through the cracks.
And then Commissioner Miller.
Thank you. I have a few questions. The first one is about funding. So I totally understand that part of the problem, as you and Commissioner Sherman have discussed, is lack of sufficient staff to cope with this overwhelming problem. And I guess I want to know where your funding comes from. Are you funded through the Sheriff's Department, or are you funded through elsewhere?
No, we as was said earlier in the meeting, we are not part of the Sheriff's Department. We are a department within Department of Health Services. So we're part of Health Services, and we're funded through the general fund.
So if we were to raise this issue of funding on your behalf with someone else, it would be with the Board of Supervisors, essentially. Is that right?
Yeah, I think with the board, I believe it'd be with the board and the CEO's office.
Okay,
or the board or the CEO's office through the board. Yeah, but yeah,
Right.
That's where our funding comes from.
Next question is, I think, I don't think we've discussed it in the commission hearings expressly, but it strikes me, given what you have said, that one of the big problems that we are seeing here is that the courts are sending lots of people with mental health problems to the jails. And who knows, the courts may be thinking that they can get mental health treatment in the jails. It's clear from what you said that the jails are overwhelmed and are not an appropriate site for, as it were, sort of first look mental health treatment. So, so first of all, I want just to emphasize that I think it's consistent with some of what Commissioner Sherman is saying about who can say no to sending people to jails, and that it is deeply inappropriate for courts to send people to the jail who are suffering from significant mental health problems if those individuals can be safely placed elsewhere in the community. But I also wondered if you have communicated with the courts that they ought to try and find alternative ways to house people with mental illnesses other than in the jails.
Yeah, and yes, we have, and I think they have. For example, the Office of Diversion and Reentry, it's my understanding, we work very closely with them, but it's my understanding their beds have been filled for a very long time. They have very little turnover. And so the places that do, house and care for our mentally ill are all generally at capacity. There's just not enough community capacity to take to take on the burden of the jail. If we had more community beds, I'm sure there were more people from this jail currently who I think courts would feel comfortable saying they can go to programs. Again, that's just my estimation, but I think that what we've run up to is a capacity problem, is that the capacity in the community is at its limit. If there were more beds in the capacity, I think it's a very safe bet that we would see some of the people who are currently housed with us not housed with us and able to go to the community.
Great, thank you.
Thank you. Thank you, Dr. Belavich. I want to start by appreciating your honesty and frankness in the dilemmas that you're facing. And it reaffirms the observations that we have that the system is broken in many respects, but particularly for our conversation now with respect to mental health services. And this was predicted that we would get to this point when the lack of wisdom and foresight was present when they decided to shut down a lot of the community mental health centers and basically defunded them. And the jails became the new community mental health centers and psychiatric facilities. And so I guess I have two questions for you. Aside from, so one of the things that I've observed is a lot of dispensing of psychotropic medication, but not a whole lot of follow-up about whether or not it's working, and it's not supplemented with any kind of behavioral interventions. And so is it fair to say that there is very, very limited psychotherapy or counseling type services available to folks in the jails?
Yes, given the number of individuals we have here, our clinicians are overwhelmed. The sheer numbers on their caseload are unmanageable. And it's created a problem that just spirals more and more. The more patients we get, the more overwhelmed our current clinicians get, the burnout comes, and how do you attract new people into this place to work, right? You've all been here. This is not, I can't offer nice offices. I can't offer, great parking. I can't offer any of those things to people. I don't have a lot to attract them. And now, how do I attract them to say, please come work with us where I can assign 250 people to your caseload? Right. And so it is very difficult. And we also don't have the space. I mean, again, I'm talking to a familiar audience because you've all been here. We don't have private offices where people are provided treatment. We don't have group rooms, in Twin Towers. They're brought out into the day room. They're brought out into, to desks in an ante room. That's where treatment's occurring. All those things are problematic.
Right, and I think I've observed, and some of the other commissioners have observed on some inspections, the fact that the kind of privacy that is needed and legally necessary is just not there. So if someone trying to talk through their issues, and you've got deputies and custody personnel standing right nearby, is in fact very problematic. So I guess my question is, what's the solution? What would make things better? Because one of the things that as a commission we would like to do is be able to work on behalf of solutions, not just finding problems, but participating in the resolution of the things that we identify. So what would be needed to fix a very, very broken scenario that people are languishing in, psychological distress, and those who are the less acute, I've been actually watching some, and they're getting more. They're transitioning to the acute phase.
Sure. Yeah, those who maybe are on the edge get sicker here. Mm-hmm. Absolutely. And so there's a few things we need, and I think some of them, we're all going to agree that I'm stating some obvious points. One is a reduction in the mentally ill population, but I think that can only be done with, with appropriate identified community resources for these individuals to still receive their treatment. We can't just release people without that net for them. But also increase staffing, which we are working on, and we're working closely with the CEO's office on increasing staffing, but also increasing staffing doesn't mean a lot if I can't attract people, right? Having a bunch of vacancies doesn't help me either. So we are working on trying to incentivize people to work in the jail, either through some type of jail-based bonus or a loan repayment program, or something that will set it apart so that people will be more willing to come to work here in the jail. And that's very common in correctional systems. Many correctional systems have what they call a jail-based bonus compared to the rest of the community, or they offer some other type of thing. We've already done what we can in terms of offering, alternative work schedules and things like that. But again, I think it's a balance of needing community placements so we can reduce the population, and then right sizing the caseloads for our clinicians, so that they can do what they went to school for and what they were actually hired to do, and that is to provide the treatment. Our goal is to actually do more than just get them their medications and check in on them. We should be providing treatment. We should be developing treatment plans and working towards goals. And with caseloads as large as they are, that's often impossible. There is a small subset who do receive that, or actually a large subset who receive that, but those generally are those who are most severely mentally ill. Another thing that we are working towards, we're working closely with the Department of State Hospitals. Currently, we have 500 individuals on the list to go to the Department of State Hospitals, and we're working. They've been very open with us when they have an increase in bed availability and offering those beds to us so that we can get more patients into those beds. And those are patients who are going for competency restoration.
That actually, and then I'll turn it to Commissioner Sherman, the competency restoration, that was an issue in one of our inspections, either at the earlier part of this year. We didn't get much traction trying to understand the issues, but there was a sense that there's a backlog around the competency restoration, and that people's rights might be violated in that regard. I'm not sure, Commissioner Varela, if you are raising your hand with respect to this particular issue. So go ahead and please feel free to weigh in.
Yeah, no, I just wanted to thank you both for bringing it up, because it connects to all the other issues we're talking about, where people are waiting for long times, but not only that, they are restored in the hospital and they come back to continue their proceedings, and the conditions at the jail unrestore them, if that's a word, because they are in IRC for a long time, or they don't get their meds, or it's a circular cycle that is really really dangerous. I've heard about, lots of public defenders have talked about this.
So I believe you were nodding in agreement, Dr. Belavich, about the competency restoration backlog.
It's been a problem for years.
Okay.
We've been in the hundreds for years. It's my understanding that Los Angeles County is responsible for about 1/3 of the incompetent to stand trial population waiting for beds at the state hospitals. So it's a very large population. We hold a very large part of the overall state population.
And again, I'm sorry.
Oh, sorry. I'm sorry. I was just gonna, and maybe, is there talk about doing the restoration at the jail? Okay.
Not at the jail. There's talk about us doing community restoration with in partnership with ODR.
Oh, okay.
Yeah. Yeah, so that would be very helpful for us because those individuals would be able to leave the jail for their competency restoration, which would help the jail population to decrease. My concern about doing jail competency restoration is it's one more mandate that we will not be able to meet.